Welcome to the Neurology Review section of the Falcon Physician Reviews course. The next section will be covering the spinal cord, and it's a heck of a lot to cover because this is an extremely clinically important part of the nervous system. So you're going to need to know this down cold. It's certainly a high-yield section of this review. First thing we want to talk about is just grossly to be able to identify segments of the spinal cord. The spinal cord is divided into the cervical, thoracic, lumbar, and sacral regions of the spinal cord. This refers to the segment of the cord, not to the vertebrae that are nearby, because nerves travel downward, or roots travel downward, before exiting at a particular vertebral level. Here's what the entire spinal cord would look like. As you can see, the roots of the spinal cord are exiting down below the area where they leave the spinal cord itself. The conus medullaris is the end of the spinal cord, and it's located in the adult at approximately L2. The roots that are extending below the conus medullaris are called the cauda equina. These will exit in sacral regions, and it allows us to be able to do a lumbar puncture in the areas below vertebral level L2 without puncturing or without poking the cord itself. The filum terminale is an extension of pia that will extend down and attach to the coccyx. Here's another look at the spinal cord. Here you see the conus medullaris, the cauda equina, and the filum terminale. Where does the conus medullaris end in the spinal cord? Well, I just told you, L2. Now, let's look at how we would identify these segments when we look at the cord in cross-section. We should know that white matter progressively increases from sacral to cervical levels. That's because, it makes intuitive sense that up in the cervical spinal cord, you have a lot of information from the body that is gathered up, ready to talk to the brain, and a lot of information from the brain passing down to the body that needs to go through the cervical spinal cord. So it makes sense that the cervical spinal cord is going to have a heck of a lot of white matter. Whereas when we're in the sacral spinal cord, the amount of white matter is very little. The only thing that you have that you're carrying information from is from the perianal region and sphincter. So essentially, you're going to have very little white matter in that area. So if we were to look at the segments, let's use a couple of things to try to determine whether we're up in the spinal cord, up real high, or down low. Another thing that we can use to make a guess at where we are in the spinal cord is the size of the ventral horn. The ventral horn contains motor neurons that are going out to innervate muscles. If those motor neurons are needing to go off to an arm or a leg, there's going to have to be a lot of cells there because there's a lot of muscles in the arms and the leg, as opposed to when it's in an area that just needs to innervate muscles of the trunk, such as the erector spinae or intercostals or abdominals. Not so many muscles, probably a smaller ventral horn. So if you see a large swollen ventral horn, it's going to suggest that you're either in the cervical or lumbar region of the cord. Now let's look at a region that's in the thoracic region of the cord. Look at the ventral horn here. It's much smaller than what we just saw in the last slide. Another thing that you can use to suggest that you're in the thoracic spinal cord is a couple of landmarks. One is the intermediolateral cell column, and the other is called Clark's column. They are, the intermediolateral cell column is just a little nubbin of tissue that's extending off the side of the gray matter of the spinal cord. And the Clark's column is just a swelling of gray matter that's in the dorsal horn. These are present from T1 to L2. So if you see these structures, you know that you're somewhere between T1 to L2. One other thing that you can use is that the shape of the spinal cord tends to change from round to oval as you extend up the cord. So that cervical spinal cord is going to look more oval than down below those levels, as you can see in this slide here. Now let's talk about tracts of the spinal cord. Funiculi refers to a group of white matter tracts. So here we see the posterior funiculus, the lateral funiculus, and the anterior funiculus. The posterior funiculus is located between the two dorsal horns of the gray matter of the spinal cord. The lateral funiculus is between the dorsal horn and the ventral horn of the spinal cord out to the side. The anterior funiculus would be located between the two ventral horns. But we can divide this much further. If you look at the ascending pathways of the spinal cord, the posterior columns are represented in this image by numbers 1 and 2. The posterior columns are divided into the fasciculus gracilis and the fasciculus cuneatus. The fasciculus gracilis represents information coming from the lower half of the body. So we would say the legs. And it's very easy to remember that because there is a gracilis muscle in the leg. So that should help you remember that gracilis represents information coming from the leg. Other people use the mnemonic graceful legs. So that may be something that can help you memorize this. Fasciculus cuneatus is representing information from the upper part of the body, so you can think of it as representing information from the arms, and that will help you. All right, let's talk about what they convey. Posterior columns convey the following modalities of sensory information: two-point discrimination, vibration, conscious proprioception, and stereognosis. The two that we really test clinically in the neurology clinic and on the wards are vibration and conscious proprioception. Very important things to be able to test, and most non-neurologists don't test this, but it does give us a lot of information about what areas of the cord are intact and which areas are damaged. So to test vibration, we usually take a tuning fork and bang it and put it on a knuckle or an area of bone and see if the person can sense whether the vibration is occurring or not. Conscious proprioception requires us to wiggle the toe or the finger, and the person needs to know whether the finger or toe moved up or down. We make very subtle movements of that toe or finger, and they should be able to detect which direction we just moved it, even with their eyes closed. That would be conscious proprioception, and that is carried by the posterior columns. So this input stays ipsilateral before synapsing in the brainstem. So let's follow this through. Information from the peripheral nerve enters through the dorsal root and enters into, if this is coming from the upper arm, it will go into fasciculus cuneatus, which you see here in blue, and that is ipsilateral, or the same side as the information was perceived on the body. So now let's move forward and say, where is neuron number 1 of this? Meaning, where is the cell body of the neuron that took this information and is conveying it? Well, the cell body is actually in the dorsal root ganglion. Okay, that's important to know. We call that the primary cell of the dorsal column system. How does it get to the brain? Well, it travels through fasciculus gracilis or cuneatus, as I just told you. And where will it terminate? Well, it'll go all the way up to the brainstem, and it will terminate in the nucleus cuneatus if it's coming from the upper body, if the information is coming from the upper body, or it will terminate in the nucleus gracilis if that information is coming from the lower body. Now, let's talk about the spinal thalamic tract. This is represented by number 5 in this image. It conveys pain and temperature. We test that by taking a disposable safety pin and gently poking the skin of the patient, and if they can detect that as sharp, then their spinal thalamic tract is intact. Sometimes, if you're from a cold climate, you may have a cold tuning fork that was in your pocket as you were outside, and you may be able to use that. But the preferred method is using a pin to determine if the person has pain and temperature sensation. So let's follow this track. The fibers from these pain and temperature neurons will enter the Lissauer's fasciculus of the spinal cord. At that point, they ascend a couple of levels and enter the dorsal horn, and they synapse. At that point, they will cross via the anterior white commissure. It's very important to know this is a big difference between the spinal thalamic tract and the dorsal column tract. The spinal thalamic tract has information that crosses to the other side immediately as it enters the cord. It also synapses. That's different than the dorsal columns. So this will then go to the contralateral side of the cord and ascend through the brainstem into the thalamus. So let's see it here. So the information from pain and temperature enters into the cord via the dorsal root and synapses in the dorsal horn, crosses to the other side, and ascends in the spinal thalamic tract. Here it is again. We see a small diameter primary afferent fiber where the neuron number 1 is, same as in the dorsal column system. The neuron number 1 is in the dorsal root ganglion. Then information synapses in the substantia gelatinosa. That's where the second order neuron will be located. That's the second neuron of this whole system. So information comes from the tissue, from the skin, and makes it into the cord, synapses in the substantia gelatinosa, crosses to the other side, and ascends through the spinal thalamic tract, as you see here. Cross through the ventral white commissure and ascends in the spinal thalamic tract, seen here in green. Now let's talk about a descending pathway. The corticospinal tract is extremely important and another tract that we test clinically in patients. This is represented by number 4 in this image. What does it convey? Motor signals from the cortex to the ventral horn. So information come from the precentral gyrus of the cortex will descend and synapse on the ventral horn of the spinal cord. This descending pathway is crossed already in the lower medulla before it enters the cord. Therefore, a right-sided lesion of the corticospinal tract in the cord leads to deficits on which side of the body? Well, I just told you it should be ipsilateral if it's in the cord, so therefore it should be on the right side of the body that is weak. Here we see the area of the corticospinal tract conveying motor signals from the cortex to the ventral horn. The ventral horn will contain the motor neurons that ultimately project to the muscle. So this is a 2-neuron system, and it's extremely important to remember that there are two neurons here, because lesioning one neuron will have very different effects than lesioning the other neuron. And that's why it's called upper motor neuron versus lower motor neuron deficits. If I damage the neuron that is up in the brain from the precentral gyrus extending on down to where it synapses in the ventral horn, that is called an upper motor neuron lesion. If I damage the neuron that's sitting in the ventral horn and talking directly to the muscle, that's called a lower motor neuron lesion. Let's see what it does differently. First, let's go through the corticospinal tract itself. You see that it originates in the primary motor cortex. It goes through the posterior limb of the internal capsule. We'll talk about that in another section. Via the pyramids of the medulla, and then enters the spinal cord and eventually synapses in the ventral horn. When you lesion the neuron that is before the synapse in the ventral horn, it's called an upper motor neuron lesion. If you lesion the lower, the other neuron, the neuron in the ventral horn, or its axons that project out of the cord, that's called lower motor neuron lesion. What happens when you have an upper motor neuron lesion? Well, that will result in spasticity, hyperreflexia, and an extensor plantar response that is known as a positive Babinski sign. A lower motor neuron lesion will lead to flaccidity, or lack of tone in the muscle, a loss of reflexes, and a more rapid atrophy of the muscles. Atrophy will occur in an upper motor neuron lesion but we call that a disuse atrophy, and it occurs much later than what you see in a lower motor neuron lesion. Let's talk about somatotopic organization of the cord. Somatotopic organization means that different portions of the cord are carrying information from different portions of the body. We already talked about how fasciculus gracilis of the dorsal column has lower body information being represented in the medial portion of the dorsal column, and upper body information being represented in the lateral portion of the dorsal column. So you can see that here, where sacral to thoracic regions of the body are being represented from medial to lateral. The opposite is seen in the corticospinal tract and in the anterolateral system, or the spinal thalamic tract, where cervical region information is carried very medially and sacral region information is carried very laterally. Let's do a clinical vignette. A 45-year-old man is brought by ambulance to the emergency department of the local community hospital, complaining of an inability to move his left leg. He was stabbed in the back 2 hours ago while defending his wife from a mugger. On physical exam, you see moderate bleeding, a stab wound at the level of the posterior cervical spinal prominence, C7, of the left side, a loss of position sense of the left leg, weakness of finger flexion and extension, inability to sense vibration of tuning fork along left lower limb, loss of pain or temperature sense in the contralateral lower limb, the right side. So what would this be? Well, it's called the Brown-Séquard syndrome, and it's very important to understand. It's a very high-yield syndrome for the boards. What happens when you have a hemisection of the cord? Well, you will have an ipsilateral upper motor neuron lesion below the level of the lesion. So you'll have spasticity, an upward going toe, and hyperreflexia. Ipsilateral lower motor neuron lesion syndrome at the level of the lesion. That's because you just got the ventral horn of just that one region of the cord. You'll have ipsilateral loss of discriminative touch, sensation, and conscious proprioception below the level of lesion. So you will lose your conscious proprioception and your discriminative touch sensation below the level of lesion. Ipsilaterally, that's because of the dorsal column damage on the ipsilateral side of the cord. And here's the kicker: contralateral loss of pain and temperature sensation below the level of the lesion. That's because the spinal thalamic tract crosses before ascending to the brain. Another clinical vignette. A 30-year-old man is referred to a neurologist because of progressive anesthesia and weakness of both arms, occipital headaches, and a stiff gait. He has no history of trauma in the past, no motor deficits, lack of pain and temperature sensation in both arms and hands due to spinal thalamic tract involvement, but preserved position and tactile sensation. The dorsal columns are uninvolved and proprioceptive sensation is spared. Unimpaired pain and temperature sensation below the arms, thenar muscles of both hands are atrophied, areflexia in both upper limbs, brisk deep tendon reflexes in both lower limbs. What could this be? Well, the one thing that could be damaging just pain and temperature bilaterally, we call it a suspended level, something that could just cause pain and temperature loss right at that one level, would be something that is damaging the anterior white commissure, so the area where the spinal thalamic tract is trying to cross right at that level to get to the other side. So this would be something that is a central cord lesion, and the most likely thing is a syringomyelia. So it's caused by a syrinx. Syrinx is an enlargement of the central canal of the spinal cord, and it can compress on the anterior white commissure, and that's what's happening in this case. What if a 49-year-old man presents to your clinic with progressive weakness in both arms and hands? He has noted muscle wasting in his hands, and he's noted involuntary muscle contractions in his arms, chest, and back. He says it looks like worms crawling under the skin. He says he has no sensory symptoms, no bowel or bladder involvement, and no spinal trauma. On cranial nerve exam, you see that there's tongue fasciculations, otherwise normal. Arms and hand examination reveals bilateral wasting of the muscles throughout. and he has muscle weakness on the motor examination. He has no sensory deficits. His reflexes look depressed, but when you look at them closely, they are spreading to other areas of the arm when you tap on a tendon reflex. For example, if I tap on the bicep reflex, I see not only an arm contraction, but I also see the fingers flex. That's called spread of the reflexes, and it's a suggestion of hyperreflexia. Also seeing noted mild spasticity, and the Babinski test is positive. So he has an upper motor neuron lesion, and he has some suggestion of lower motor neuron lesion. This diffuse weakness with fasciculations in this picture, especially tongue fasciculations, suggests amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. This is an important syndrome to understand, and it is a damage to the corticospinal tract and to the neurons of the ventral horn. So it is a very serious disease that spares the person's cognition, and so it's very frustrating to treat because there's not a great treatment for it. Nothing can really extend life much more than a few months. They usually live about 5 years, but no treatment can extend life more than a few months. So we tend to sort of use supportive treatment and make sure that the subject, so that the patient has access to very supportive groups and has the ability to rely on those resources for things that are going to come up as he gets weaker and weaker. Quickly, let's talk about the vascular supply of the cord. The anterior spinal artery supplies the anterior 2/3 of the cord. It arises from the vertebral branches at the medulla, and it is supplemented by branches of the intercostals, especially a large aortic branch at the low thoracic level called the artery of Adamkiewicz. This results in watershed zones of poor reserve. A watershed zone is an area where it is at risk if global blood pressure decreases. A watershed zone is the area that's between two large vessels that are supplying a region of tissue. And so you can imagine if you're far away from the source of blood, you're going to be at risk if that source has less flow. Okay, so that's called a watershed zone. And those are found in the cord at mid-thoracic and lumbar regions. Here's a schematic of the spinal cord blood supply. The vertebrals give off the anterospinal artery, which will go down and feed the anterior 2/3 of the spinal cord. The posterior spinal arteries, there are 2 of them, and they are much smaller than the anterospinal artery. Here you see how they come off, and they are supplemented by branches of the aorta. Posterior spinal artery, there are 2 of them, and intercostal can give off things such as the artery of Adamkiewicz. If a patient is paraplegic and from the chest down cannot discriminate sharp from dull sensation or temperature, but he can tell you with his eyes closed which direction you are moving his toe, that means he has intact conscious proprioception, but everything else is damaged. The one thing that is spared is his dorsal columns. So what could do this? Well, an anterior spinal artery infarct can damage everything but the dorsal columns, and that would explain this person's syndrome. The anterior spinal artery also serves as a useful landmark to show where you are in the cord. If you see one large vessel running up and down the cord, you're going to know that you're looking at the front of the cord. And here's what it looks like on the back, where you see 2 raised bumps for the dorsal columns, and there is no large vessel running up and down the cord. Here are dorsal roots, and here are the dorsal columns. What are 2 diseases that preferentially damage the dorsal columns? This is important because it's an often tested question, and the 2 diseases are B12 deficiency, which is called subacute combined degeneration of the cord, and tabes dorsalis, resulting from neurosyphilis. And this concludes our spinal cord section of Falcon Physician Review's Neurology Review.